Mr. Chairman, ladies and gentlemen, many thanks for asking me to talk, and good morning. What I'm going to be talking about today is the management of anemia in the surgical setting, focusing on preoperative anemia. And my colleagues, Professor Hunt, will be talking about intraoperative management of bleeding, focusing on tranexamic acid. And Professor Murphy will be discussing the latest and current evidence for the need for transfusion. So my talk is to give a background about what the problem of anemia is. And it's one of the most easily correctable risk factors for patients undergoing surgery. I'm going to discuss the role of transfusion and the fact that transfusion may not be the most optimal solution in this setting. And introduce a concept of patient blood management, but focus particularly on my talk looking at the diagnosis and implications of iron deficiency and how technology and our knowledge of iron deficiency has advanced such that we now have the opportunity to treat these people in a more effective manner. I'm going to shamelessly advertise a large clinical trial that I lead called Prevalence on the role of iron therapy in surgery. And I'm going to briefly talk about and introduce the talks by Professors Hunt and Murphy, and give some examples to sum up about the work we've been doing in Western Australia, where we saved the government an order of $24 million by implementation of these processes. So a few disclosures from grants, and in America now you have to declare everything over $10, so I'd like to thank Costa Coffee for facilitating many a meeting. Now, what's the problem in surgery? This is my line of work. I'm a vascular surgeon. This is the carotid artery, which we're undertaking under local anaesthetic. This is actually on an Australian here called Bruce, believe it or not. And aneurysm surgery is now keyhole, and my aim is to keep my anaesthetist in the manner in which he's become accustomed. But the truth is not like that. The truth is that our operations are getting more complicated, and we're operating on sicker people. And transfusion, when we use it, is more poignant and more relevant than ever before. What's the global prevalence? Where's our starting point? Well, actually, if you look at the incidence of anemia globally, whether or not it's in sub-Saharan Africa or Western Europe, well, after the age of 60, there's a direct linkage between age and the prevalence of anemia. And the average age I operate on is 76 for a carotid and 72 for an aneurysm. So 30% of my patients are anemic when they come through the door, just due to their background status. And this is a very detailed modeling paper done by the Gates Foundation. And they modeled the incidence of iron deficiency anemia down here around the world. And what's interesting is that the causality of anemia in the Western world is still nutritional iron deficiency, but secondarily it's GI bleeding, it's renal dysfunction, not necessarily renal failure, and hemoglobinopathies. So key to those three things is dysfunction of the iron metabolism pathway. And that's what I'm going to go into in more detail. Now, you're very familiar with the enhanced recovery after surgery. Over the last decade, Henrik Kellett and many others have been pushing this. And what's the objective? Well, if you look at 7 key operations, totaling 120,000 patients in the UK per annum, the objective of enhanced recovery is to save money and to improve turnover through hospitals, because there's no proof that it improves patient outcomes. And if we can save just 4.5% of bed days, then we can save $250,000 bed days overall. Now, the HRG code is £258 per day, so I'll let you do the maths. So, what's the problem of anemia? Well, a variety of data out of the US Veterans Database, which is 250 hospitals throughout the US, has suggested that anemia is associated with infection, adverse events, but interestingly, the transfusion in its own right increases morbidity and mortality. The populations studied here were heterogeneous. They looked at colorectal surgery, emergency surgery, and trauma surgery. And our aim was to look in detail across their database to see if we could actually tease out independently whether anemia was associated with a worse outcome. So we looked at 9 predefined domains, and we looked at 30-day mortality, and as I mentioned, 9 predefined domains of morbidity. The overall transfusion rate was 30%, and that's pretty much standard. And we did a multivariate analysis here, controlling for 62 variables that came up. So I found someone with a very large computer and a lot of knowledge of statistics, and this is what we turned it into. So if you take your hematocrit here, so divide by 3 for hemoglobin, and declining hematocrit, so worsening anemia, this is your composite morbidity and your composite mortality. And there's a direct linear relationship between your hemoglobin and your outcome, controlling for 62 variables across 9 predefined domains. So even someone with a mild anemia, so a hemoglobin of 110, is associated with a 40% increase in morbidity and mortality. Now, my specialty of vascular surgery, following on from cardiac surgery, you can look up my results online. And if I was 40% off the normal, then I would be likely to be suspended. And as results come into our practice, as you, as general surgeons, get your results published in the Daily Telegraph, then you need to pay attention to your preoperative optimization to see whether or not you can actually change these reversible risks. So I'm just going to have a couple of quick slides here because we've got to get interactive. So could I have the interactive questions, please? There we go. So this is, have you been listening? So what percentage of patients undergoing major abdominal surgery, so a laparotomy, have anemia preoperatively? Okay, some people are very optimistic. Across the board, it's around about 30% for all. If you look at colorectal surgery, if someone's undergoing colorectal surgery for colorectal cancer or IBD, the incidence is between 55 and 60%. The lowest incident is in a primary knee replacement, which is 14%, and that's a study done on 250 hospitals around the country. If you look at gynecological surgery, it's 27%. If you look even at breast surgery, it still comes in at about 30 to 35%. So really the figure you're looking at for a laparotomy is between 35 and 45%. So next interactive slide, please. Oh, no, not that one. Great. So what is the impact if you've got someone who's got preoperative anemia, so defined at less than 120 or 130? What is the impact on that patient on the overall outcome, so in terms of morbidity and mortality? I'm glad 40% have been listening. It's 40% across the board. Irrespective, even mild anemia, it's actually 40.07% increased morbidity, and that was studied in 252,000 patients. Final slide, please. Now, we're going to be talking about intravenous iron, and you're familiar with oral iron, but intravenous iron has a dose efficacy rate, and I just wonder your familiarity with intravenous iron and how long do you think it's going to take to work? So if I gave someone 1,000 milligrams of iron, a full treatment dose, when will I see the maximal response to that? Interesting. So what I'll show you is data to back this up, but essentially you'll see about a 50% response within about 5 to 7 days, an 80% response within 14 days, and a maximal response at about 20 days. In terms of hemoglobin response, what we don't know yet is, because iron is a key substrate in the mitochondrial oxidative phosphorylation stage, is whether restoring iron status to the muscle and to the enzymes within the muscle improves oxygen extraction And there is now data out showing that it improves quality of life within 48 hours of injection. So there are two mechanisms of action. Now, going back to causality, I've said that preoperative anemia is associated with a 40% increased risk in morbidity and mortality. And many of you will use cardiopulmonary exercise testing to risk stratify your patients. So we've got a lot of experience because there's the Tour de France, and we know that if you blood dope, you have a better outcome in terms of VO2 max. So we pulled all the data from all the CPEC centres in the UK, and we showed that if you have severe anemia, mild anemia compared to normal for a matched population based on their POSSUM score, that anemia impacts on your VO2 max and your anaerobic threshold. So we haven't linked causality, but we've shown association, and we've shown association between a mechanism that we can utilize in clinical practice. So what about transfusion? I've harped on about anemia being a bad thing, and traditionally we use transfusion without thinking about it. It's readily available. It's a fantastic service. You know, you can get a matched unit of blood from blood test to the patient within 45 minutes, controlled for 200 points. It's a fantastic service. But there's a huge variability of usage, and the original work was done in orthopedics, and it showed that there was a huge variance in transfusion rates between hospitals around the country. The same is true in cardiothoracic surgery. So even for a simple CABG matching for Euroscore, the transfusion rates are between 20% and nearly 80% around the country. And we recently repeated this survey and showed a threefold variation. I have no idea why Papworth transfused so much blood. What's the impact? Well, Vic Ferraris went back and looked at just under 1 million patients, and he showed quite interestingly that yes, if you have a major transfusion as defined by more than 5 or 6 units of blood, your morbidity or mortality is increased. You would expect that, because if it's really difficult surgery and you need lots of blood, you're more likely to have a bad outcome. But this is very interesting. Even receiving a single unit of blood increases your mortality by 10%. But it doesn't quite make sense, because if you take stable people who are not undergoing surgery and you give them a unit of blood, you increase their VO2 max and you increase their quality of life. So the interplay between anemia and transfusion is slightly unclear. And we don't really know which is the worst one, but what we do know is the more anemic you are, the more likely you're going to be transfused and the worse your outcome. So we looked at gynecological surgery because one of the criticisms of our paper, taking 250,000 people, is that there was a heterogeneous group, and actually, look, you're just saying that sicker people are more likely to be anemic and sicker people do worse. Well, that's kind of obvious, but that's the perils of associative data. So we wanted to look at gynecological surgery, and the reason was these are relatively fit and healthy women who have few comorbidities, and the indication for a simple hysterectomy is often due to benign disease. And so the average age is 48. Again, the anemia rate is about a quarter, and those getting with anemia are more likely to be transfused. So we did exactly the same analysis as we did in the Lancet paper, and we showed a 5-fold variance in mortality between those people who had preoperative anemia and those people who were not anemic. And we showed increased complication rates along all the 9 predefined domains. And so what we're doing here is we're saying that if you have sepsis, your overall complication rate goes up by that much. But if you have sepsis and anemia, it's an additive impact. And if you look at propensity scores, we've got exactly the same. Because numbers are smaller, we had to do it in a statistical modeling. There was only 14,000 in the set. But we've shown that for declining hematocrit, both your morbidity and your mortality is increased. And what we tried to show is that the impact of anemia and transfusion appeared to be additive, so that transfusion doesn't correct the worsening impact of anemia, it actually makes it worse. So how do we treat this? Well, a new paradigm is coming about, and it was developed in Western Australia. over the last 7 years. And the NHS has implemented this in the last 9 months. So the Department of Health has supported patient blood management, the future of transfusion in the UK. And currently sequin targets are being proposed to NHS England to be implemented into trusts within the next 12 months. And in there will be transfusion rates and preoperative anemia, we hope. And patient blood management involves 3 pillars: optimizing erythropoiesis, minimizing blood loss and bleeding, which you'll hear about from Professor Hunt, and harnessing and optimizing physiological reserve of anemia. And you'll hear about transfusion practices from Professor Murphy. So what about anemia? This is my interest and what I'm going to be talking about. So looking at your iron distribution, in the most part, your iron is distributed and held by the red cells through the reticular endothelial system. And as the red cells are processed, the transporter mechanism of taking the iron out of the red cell and redistributing it back to the bone marrow is essentially a reticular endothelial system. And at any one point in time, you've got about 4 grams of iron in the body. Putting this into perspective, the average female in a year with normal menses will lose 6 grams a year. A unit of blood is about 200 milligrams of iron. So if you as a surgeon use a unit of blood on the floor, you're losing that patient 200 to 300 milligrams of iron. Now, EPO is your stimulant and iron is your substrate to make your red cells. And the way we measure it, and I'll skip through this, is ferritin is one of your generic stores. Essentially, it's a cage for iron. But the transferrin is the transport protein that delivers your iron around the body, and you can measure this using transferrin saturations. You can also look at percentage hyperchromic red cells, and you can get this on most blood results with a low hemoglobin density measurement, and it can be expressed as a percentage as well. Now, what happens in a state of chronic disease? You've heard me talk about anemia, but traditionally in surgery, we say that this is anemia chronic disease. We now know that iron is the key process within that chronic disease. And if you have active inflammation or lipopolysaccharide, it activates a key protein from the liver called hepcidin. What hepcidin does is it shuts down ferroportin, which is the transport protein of iron. So although you have iron in the stomach in your diet, you can't get the iron out because the transport protein is downregulated. Your macrophages will take up and store iron as ferritin, but they can't transport it out. EPO is downregulated as well, and the consequence is to develop poor quality and lesser red cells from the bone marrow. Now, this is a very pivotal trial, and it was done in heart failure. So 30% of people with heart failure have an iron deficiency. And they describe this as an absolute iron deficiency or a functional iron deficiency. And by a functional iron deficiency, I revert back to the previous slide, it's where you have a state of inflammation where you take up and you store iron as ferritin, but you don't release it to the bone marrow. So your reticular endothelial system and your recycling pathway for iron is blocked. So although the blood test says you've got a high ferritin, you're functionally deficient, you can't utilize that. And what they did is they gave these people intravenous iron, and they randomized the 2 groups, and one group got intravenous iron and one got placebo. So intravenous iron, which I'll come on to in a sec, bypasses the system and is delivered effectively through the macrophages and into the bone marrow. And what they showed is that they improved not only the quality of life, the heart failure status, the 6-minute walk test, and I bring you back to the CPET tests I mentioned earlier, and also the overall EQ5D. These results have now been validated in a follow-up study and have shown that if you replenish people with cardiac disease with intravenous iron, you reduce morbidity and mortality from cardiac-related complications over time, and you reduce readmission to hospital. This was controlled for hemoglobin, so the results are independent of the hemoglobin. A lot has been developed with iron. We're probably all very familiar with the old iron dextrans, which were associated with anaphylaxis. Newer preparations enable a full treatment dose of iron to be delivered within a 30-minute infusion period without the risk of anaphylaxis. Anaphylaxis developed because humans have preformed antibodies to dextran. So the newer preparations are this one, which is iron carboxymaltose, is a carboxymaltose shell, and this one, which is Monifer, is a similar preparation. So they're effectively far safer than the older preparations. They're off the shelf. You can even give them in outpatients. And do they work? Well, if you give a full treatment dose of 1,000 to 1,600 milligrams, you get a far better response compared to the old iron sucrose. And looking at response over time, iron carboxymaltose is far superior. So, moving forwards. How do we improve our patients' iron deficiency? Well, you've got heme iron with vitamin C and lysine. Very good for patients as well as surgeons. So, we took 1,500 patients undergoing surgery at our hospital, and my research fellow sat in pre-assessment clinic day after day after day for 4 months. We defined 700 patients who stayed in hospital more than 48 hours, and the results are unsurprising. 30% are anemic. If you're anemic, you're more likely to be transfused. If you're more likely to be transfused, you're more likely to get 3 units of blood compared to 2 units of blood. Extrapolate this across the whole hospital and 7,000 operations a year. The difference is in the order of £120,000. A bag of blood, to put this into perspective, comes in at £130. That means 1 drop of blood is €1. Well, these are the results of all those patients. So if you go back to that textbook definition, you want a true absolute iron deficiency, low MCV, low MCH, low ferritin. Of 1,500 patients, you'll pick up 7. It's pretty useless, actually. Can't really do much with that. What are we doing about the other 1,493 patients? But if you go for a functional iron deficiency as defined by a ferritin of less than 100 or a TSATs less than 20, you'll pick up 2/3 of people. And that's something you can do tomorrow. And there's a direct linkage between these levels and inflammation. Now, if you use intravenous iron in surgery, it's been tested in a variety of observational studies, predominantly out of the Spanish group. And intravenous iron can correct anemia in approximately 2/3 to 3/4 of patients prior to surgery. And the efficacy of the iron is related to how anemic you are at the beginning. So the more anemic you are, the greater the response. So you should anticipate a response of correcting anemia in about 60% of people, or increasing the hemoglobin level by 80% within 2 weeks. We've done the Cochrane analysis looking at this, and we've shown that intravenous iron compared to control will significantly increase your hemoglobin. However, trials to date have not translated this efficacy into effect in the setting of surgery. So we don't know how this translates in the surgical setting to reducing transfusion or to making a patient feel better and recover faster. So we took the diagnosis of iron deficiency in all these trials, and again, it's really quite variable. We still truly don't know in whom a responder will be to intravenous iron or iron therapy. We truly don't know the causality or the linkage between iron deficiency and outcome. So we're doing the randomized controlled trial at the moment, which is called Prevent. This is an NHIR HTA trial running throughout the UK and 35 centres. And we need you, the surgeons, on board. We need you behind this because we're doing very well at the moment and we're entering into our final year. So we're taking people who have anemia prior to surgery, and 10 days before their operation, they're randomized to a full treatment dose of intravenous iron compared to placebo. We will then follow these patients up, 500 patients, over a 3 to 6 month period. It's based on strong pilot data that I've mentioned to you, and we're aiming to treat anemia independent of any baseline variable. So I'm proposing that the definition of iron deficiency, what you used to call anemia chronic disease, is actually anemia that responds to intravenous iron. We've got a variety of endpoints. It's a multidisciplinary trial, and it's endorsed by NHSBT. The randomization is minimized for severe versus moderate anemia and also extremes of age, or older versus younger, and center and operation type based on the Bupa coding. And what we're trying to do is these are slightly old results now, but we're aiming to reduce transfusion rates by about 13% or a third overall. This is the flow diagram. And essentially the good news is, as a surgeon, you don't need to do anything at all. Absolutely nothing. Just tell us about your patient. But we're doing a variety of baseline tests, including quality of life years. We're doing baseline laboratory samples and core samples. And the patients will be randomized in pre-assessment clinic, and that is it. You have no further input. So when the patient comes through to surgery, you have no idea what that patient got. You'll be blinded to their treatment. And you manage that patient as normal. But we'll be collecting data on their post-operative outcome, their morbidity scores, and over time we'll be using health resource utilization data as well. The primary endpoint is frequency of blood transfusion, because based on the Cochrane we couldn't power it for anything else. However, a power study to look for mortality difference would need about 1,700 to 2,000 patients. We'll be detailing all post-operative complications, fatigue, etc., etc., etc. And specifically we'll be looking at mortality as well. The co-primary endpoint, as we've evolved this, is to look at an event of a unit of blood or death. And we include other things such as infection and wound healing, which is highly relevant and been linked both to iron therapy and anemia. So what's the intent? How could this possibly work? How could it change? Well, if we aim to reduce transfusion by 14%, in our patients that we study, if we extrapolate this backwards using that enhanced recovery after surgery data I showed you at the start, and I took and measured the different variances of between colorectal surgery, prostatic surgery, and orthopedic surgery, I'm looking to reduce 1 day length of stay in 4.5% of people. And I'm reduce complications from 5,000 patients out of that 170,000 that I mentioned. That would be the saving to the NHS. And I think money talks for most surgeons. So this is the team. It's based out of, you'll recognize some of these names. It's based out of London School of Hygiene and Tropical Medicine. And as with British cycling, it's all about teams work and teamsmanship. And just translating this, and I'm going to leave you with a couple of final slides in the last 2 minutes. In Western Australia, 3 years ago, in 2007, they were facing a rising cost across the state of the use of blood. And Western Australia is the most isolated place in the world. It's got a population of 2.4 million, and it's 6 hours from anywhere. So essentially you have a ruptured aneurysm. That's it. That's the blood stock gone. There is none. So there was the cost. So in Australia alone, the cost of the government to the National Blood Authority is $1 billion a year. It's about the same in pounds in the UK. That's the second largest cheque that the government writes after defence. And it's going up year on year. So we looked at 40,000 units of blood, and we looked at different aspects of what we can do. Major hemorrhage. So in major hemorrhage, was cell salvage and tranexamic acid used? And you'll hear more about that from Professor Hunt. We looked also at the preoperative transfusion rates to see who are these population, who are anemic, and could we introduce protocols of iron therapy, which is what we did. And we looked at post-operative, the trigger index for transfusion. Did these people needed to be transfused? And we devised a series of implementations based on best practice at that time in 2007, 2008. And we educated the population, we educated doctors, and we managed to data link. So I could tell you the transfusion rates for the orthopedic department at the Fiona Stanley compared to the orthopedic department at Fremantle Hospital. And there's nothing but like a bit of competition between surgeons to achieve results. So what did we show? We showed a stepwise decrease in transfusion utilization despite an increase in number of operations. We showed that the trigger index to which you transfuse across the state had declined over 5 years. We had a projected total expenditure of just under $100 million, but over that 5-year period, we had a direct saving in red cells alone of just under $5 million, with a total indirect savings of $25 million in 5 years. To the state, that was a great asset. In 2009, this got adopted throughout the country of Australia. And last year, the government was returned $112 million from the NBA for excess expenditure. This has been introduced in the UK in the last 18 months. And we hope that our randomized controlled trial will contribute towards the evidence. And if you wish to make contact. This is us, and this is our team. It's my wife, colorectal surgeon, upper GI surgeon, completing the Dubai Ironman. So practice what you preach. Thank you very much.